So I'm going to talk about simulation, and I'm going to talk about simulation particularly in healthcare, and I want to talk about whether it's effective or not in healthcare. And to put things into context, I'm going to talk about what simulation is. Then I'm going to talk about how we use simulation in medicine. I'm going to talk about what matters to us in medicine in terms of learning outcomes from simulation or teaching. And then I'm going to look at some of the evidence for the effectiveness of simulation. Some of you may have seen this before. If you listen to things like me today, when you go away, you'll probably only remember 10% of what you've heard, 10 to 20% of what you heard. But if you actually are involved in doing things, or doing things that are actually simulating the actual experience, then you will retain a lot more and learn a lot more later on to be used in your practice, whether it be in medicine or in any other walk of life. So simulation in medicine and in other areas is geared towards getting people to learn and retain more. We can define simulation as a person, a device, or a set of conditions which attempt to present education authentically. And the trainee, whoever it is, they might be a teaching trainee, a student, or a young doctor, they're required to respond as under natural circumstances, and they'll get feedback about how they've done as if they had been in a real situation. There are two terms that are used for simulation that I've put up here: high tech and high fidelity. High technology basically means that the simulator we're using, and I'll show you some later, it's related to the technical prowess of the simulator that we use. High fidelity is nothing to do with technicality, it's to do with how much the situation that you're simulating reflects real life. And I'll show you some of that a little bit later on. So what simulation measures and can look at is practical skills. So if you're a doctor, it's putting things, drips in and lines in and so on. Management of clinical situations or specific situations, and also it can look at team working and communication aspects of anybody's role in a situation. So the idea of simulation, so I hope you understand this now, is to practice and to review human performance, your own performance and your interactions in a safe environment. You're not going to kill anybody in a simulation, particularly as a junior doctor. And then you get debriefed and it's discussed with you how you performed, and then you're able to use that experience in real life and potentially be safer. Some of the factors which affect human performance, which I'm going to talk about before we talk about specifics of simulation, are called human factors. And I want to show you some aspects of those for the next 5 minutes. First of all, I want you to watch this video.
Again, this is the USS Montana requesting that you immediately divert your course 15 degrees to the north to avoid a collision. Over.
Please divert your course 15 degrees to the south to avoid collision.
This is Captain Hancock. You will divert your course. Over.
Negative, Captain. I'm not moving anything. Change your course. Over.
So, this is the USS Montana, the second largest vessel in the North Atlantic Fleet. You will change course 15 degrees north, or I will be forced to take measures to ensure the safety of this ship. Over.
This is the lighthouse, mate. It's your call.
There was a problem there, wasn't there? There was a problem there with communication. There were two people on the end of that radio who were in completely different situations and were not communicating to each other. And although that's quite amusing, basically a human factor when we do things in real life and what we look at when we do simulation is communication. And you can see here that the spoken word, visual cues, auditory cues, the tone of voice, the body language that people use, and written words are all used in real life to communicate. And it's very important in our simulation that we look at how people are utilizing communication. Another area that's important in simulation is leadership and followership. That's a rather bizarre view of leadership. One way of looking at leadership is looking at Simon and Garfunkel's seminal work, Bridge Over Troubled Water. Many of you will be far too young to even remember or know this exists. But I'll use that to just show you what aspects of leadership are good and are bad. Leadership's very important because you can influence people, you can respect, you need to show respect for the people you're leading. Again, you have to communicate, and it's important for the leader to clarify roles. And in a simulation, that's just as important as in real life. So leaders direct people towards their objective, they delegate, and they support people. And Art Garfunkel on the front there, the guy at the front, is clearly doing that. He's directing the guy behind him towards the objective, he's supporting him, and so on. But followers also need to be active participants, and Paul Simon is pretty blind to where he's going, and he's just resting on Art Garfunkel there. So it's very important in simulations and in real medical emergency situations that people who are not the leader need to be supportive of the leader and follow that leader and support him or her in what they're doing. Teamworking is important. A team is a group who interact towards a common goal. A group is just a load of people doing their own thing in a room. A team is a group of people who interact, and that's very important in our specialty in medicine, and it's very important in other areas, I'm sure. And it's something we look at in simulation. People in a group, in a team, need to be interdependent and have specific roles and functions. And clearly, in this team of two, some trust has to be there. If that woman did not trust that man, they would not be a team. Finally, there's a thing called situational awareness. And situational awareness is something about understanding what is going on around you. This is a major emergency in an accident and emergency department in a hospital. There must be about 15 to 20 people there. It's very easy for people to get focused in on one particular task. That lady's fixing that guy or woman's leg, and to not actually see what everybody else is doing around you. So it's very important to be aware what everybody else is doing in the team and not get focused on what you're doing. These divers clearly have lost all situational awareness, telling the people who's taking the pictures that everything's fine and they're just about to be eaten by a shark. Now, in our lives, we can lose situational awareness. And those of you who drive, I bet you've been in this position of losing situational awareness. Cars stopping or slowing down ahead. Those behind not realising or noticing it till the last minute. I've been in that situation. Cars changing lanes without realising there's somebody coming up behind. We've all been there. Cars cruising slowly down the outside lane of the motorway. That's not me, but I'm irritated by those who do that, oblivious to the large queue of traffic. All of that is minor losses of situational awareness, understanding what's going on around you, that we come across. I'd like to show you another video.
The monkey business illusion. Count how many times the players wearing white pass the ball. The correct answer is 16 passes. Did you spot the gorilla? For people who haven't seen or heard about a video like this before, about half missed the gorilla. If you knew about the gorilla, you probably saw it, but did you notice the curtain changing color or the player on the black team leaving the game? Let's rewind and watch it again. Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold.
It's amazing, isn't it? It's amazing. That's a really important video because that just shows I've asked you all to concentrate on something. And if I did that in my medical job and was concentrating on one thing, not just counting the passes, but doing something really important, I could miss a whole load of really important other things around me. And there have been cases of people who have focused on life-saving measures and have basically let the patient die in front of them because they've not focused on everything else that's going around. So it's very important. Now, before we move on to medical simulation, there are simulators in other industries. And the classical one is simulation for flight. And here's an example of what pilots do before they're allowed to actually fly real planes. And they're given all sorts of scenarios to enable them to practice for real life. There's a real life landing on water. Do you remember that in the Hudson River a couple of years ago? Now, interestingly, when pilots do flight simulation, the one thing they do not practice in the simulator is landing on water, because nobody ever survives landing on water, and it's not worth practicing it. So actually, this guy that landed on water had never practiced this before. And often people tell me in the airline industry that sometimes pilots, this is not to scare you, but sometimes pilots will actually turn the plane onto manual to land it because they're worried they're in the simulator next week and they're going to be assessed on how good they are at flying, and they haven't practiced landing the plane manually. So they're actually using a real flight to get ready for the simulator. That's not to scare you at all. But I was told that by somebody who does simulation training in the airline industry. So very important. But what about the healthcare context? We've got a whole complex system there on the left with all sorts of things going on. We often have inadequacies in the system itself. But human performance, which is related to all those things I've just told you, are much more likely to impinge on the system, meaning that there might be a possibility of suboptimal care or error. And in fact, communication particularly was found to be the leading cause of medication errors, delays in treatment, and wrong site of surgery, taking out the wrong side of the kidney, for example, the wrong kidney on the wrong side. Over 60% of errors are communication failures. So all those things I've told you before are very important. Now, what about the national strategy for simulation to help us to deal with those things that I hope I've shown you are easily done and easily missed? Well, junior doctors now have a reduction in hours. People think that increases the risk of them making errors because they work less hours, but equally they're less tired, so it might be better. And the chief medical officer some years ago suggested that because junior doctors physically work less with patients, that we should try and support their training with simulation. And there's been a lot of money to try and develop that, both regionally and nationally. And what we do in simulation in healthcare is, just as I said before, we look at practical skills, we look at clinical management, looking after patients, what decisions need to be made about various drugs and so on, and we look at team working and communication. And these are the sorts of simulators that we use. So in my specialty, which is babies, we have a baby here that you can hear the heart rate on, you can hear the breathing on, you can put an endotracheal tube down to make the baby get better. This baby's wired up so that somebody behind a one-way mirror can alter the baby's heart rate depending on how well you're doing. You can have major trauma there, blood and guts everywhere. You've got another baby there, you've got an adult simulator there who can speak. Somebody behind a one-way mirror speaks into a microphone and it speaks at the people who are actually looking after it. So incredibly high tech and high fidelity now. And this is an example of what we do in simulation. You would have your simulation room with the dummy there. You would have a one-way mirror with this individual controlling all the vital signs of the dummy: heart rate, breathing, everything, blood pressure. And whatever, if the people resuscitate or look after that dummy properly, that controller will make the dummy better. But if they don't, things will get worse, and they have to respond to that. And then afterwards, they get debriefed and watch a video of themselves doing all that, which is really quite stressful for everyone concerned. So what matters in healthcare? Well, when we do simulation training, you can look at it on 4 levels, and I'm briefly going to whiz through these. And these are called the Kirkpatrick levels. You ask people whether they're satisfied with training. That's called Kirkpatrick level 1. Well, most people are happy to be trained. It doesn't really matter, though, whether they're happy or not to be trained. What matters is whether they've learnt anything. So Kirkpatrick level 2 is about whether they've learnt something. And lots of people, if you look at big studies, have reported that they learn from simulation training. Here's a systematic review of technology-enhanced simulation, which looked at computers, mannequins, animals, specimens, looking at surgery, resuscitation, and so on. And that systematic review, which looked at all the outcomes of those studies, showed that if you use simulation or technology-enhanced simulation versus nothing, and compared the group that you simulated with the group that you didn't, and there were 609 papers on that, then the outcomes are always good with respect to knowledge afterwards. People do learn by going on simulation courses, but we conducted a systematic review looking at all the studies in resuscitation. And what we were interested in was not whether people learnt on the day. What matters is, do you carry on? Do you change your practice? Do you remember what you learnt? And we found that, you don't need to read all of this, but along the left here are 4 authors for an example. This is the number of participants in the groups. And these groups were tested again on the exam that they took at the end of the simulation course. Some of the exam was a practical exam, and all of them had lost their skills by the end, by up to 4 to 8 months afterwards. So people learn on the day, they pass their exam, 4 to 8 months later, they've lost those skills. And I think what we think from that systematic review is that you get people up to a certain standard by the course that you're giving, but over a period of time, those skills and knowledge deteriorate. And there must be something else that you can do, like a booster session, to try and keep people up with their skills. So that's learning that gets lost later on. But what we really care about is people working in clinical practice, whether looking after patients is better after I've been on a simulation course. And that's called Kirkpatrick Level 3. And in fact, there is evidence that doing that makes people do things better. So here's an example of people that went on a simulation course compared to those that hadn't. And for example, the people that went on the course to learn how to put venous catheters in, long plastic tubes into a vein to feed people with nutrition, there were much fewer complications if you'd done it on a simulator first. Real life operating, if you operate on a simulator, you're much better at it in real life later on than if you haven't. And cardiac arrest teams do better if they have to do it on a dummy first and get things wrong and learn from that. So there is evidence that people learn in the clinical environment. The key to doing that, the key to learning in the clinical environment, is that it's to do with the exposure to the simulation. And there are 2 other reviews that have looked at all the papers that have investigated this. And this first one showed that in 31 studies there was a dose effect. So the more simulation you do, the more you learn later on. There is a dose effect. If you do a 1-day course, you're less likely to learn compared to a 2-day course. And then another study showed that if you have more than 1 day, which I've already said, but if you have something called a mastery model, where, okay, you learn on the simulation course, but then you have someone that tests you in the clinical environment, or the environment that you're working in later on, and feeds back to you, you will then master that process. And that mastery model absolutely is top of the list for making people learn, remember, and look after patients better. So the real thing that matters then is making patients better and perhaps making organisations work better. And this systematic review, again with 609 papers, did show a positive effect on patient care in that different illnesses were identified better if people had been on a simulation course. Patient discomfort was identified and people were treated for pain earlier. Patient survival was better. That's a fantastic outcome, isn't it? You go on a simulation course and you know that you're actually going to increase the survival of your patients. And the rates of complications were lower. We looked at our systematic review to see whether there was evidence to patients as well. And we found that actually the introduction of resuscitation training, and this is in the newborn babies. 4 references down the side. These were the periods that these studies were carried out, usually over quite long periods, 3 years, another 1985 to 88 until 91 to 95, pre-training period of 3 years, post-training 3 years. But all these studies, if you read that final column, show that after training, there was a significant improvement in things called the APGAR score and mortality in that last column. So babies got better and died less if people went on simulation courses. The problem is, all of these studies have looked at units and departments that really haven't had any training, any formal training. They may have trained at medical school or nursing school, but there's no formal ongoing training. So it's a very low baseline. And what they've managed to get these people up to is being proficient. I would argue that, certainly in the UK, we are at the proficient to good level. And our challenge with simulation is to get people even better to be excellent, which means that, you know, the best we could ever be. That's the actual challenge in simulation. I've got a little bit of time left, and I want to show you a couple more videos of the situational awareness issue, and the issue about how in real life we can hone in on one thing and perhaps not see other things.
Watch this next sequence carefully. At the end, I'll ask you a question about what you've seen.
Hi, I'm Magic Singh, and today we're in Portobello Road, and I'm going to show you guys a classic in magic, using matches. And today to help me out is Mark. Mark, tell you what, place your hand up for me nice and flat. Now I promise this won't hurt, all right? So here's the idea. Let's just light this up, and if you close onto that nice and tight, here we go, watch this.
Keep watching.
Don't know if you felt that or not. I'll tell you what, have a look inside. Open it up. See how the match is actually returned into the book, and it's still burnt. Okay, you're not impressed. All right, it was my first trick ever. But here's the idea. Just place that back in your hand, close it tight, and turn it face down again if you can. Now we're going to use one more thing, and we're going to use a magician's best friend, playing cards. Now the idea is really simple. You're going to choose one, so take anyone you like. Perfect. Have a look for yourself. And do me a favour, show the camera as well if you can. Brilliant. And you know what? Place it back face up on the deck. Now, it doesn't matter if I see what the card is, because we're going to do something completely different. Just watch this. Here we go. I'll do it slowly. Watch the king. I don't know if you felt that or not. Tell you what, have a look inside. Open it up.
Oh.
Check it out.
It's the King of Diamonds. It's my card.
Brilliant. Thank you very much.
Thanks very much.
Did you watch the trick closely? This is a famous illusion called inattention blindness. This illusion is not about the magic. While watching the routine, you may or may not have noticed the changes taking place. The question is, how many changes did you see? Was there 1? Were there 3? Or were there 5?
Let me tell you, there were 3 changes. Magic Singh's shirt changed from white to blue. The guy who was holding his hand out was a completely different bloke at the end of it than at the beginning. I'm not going to show it again because it'll take up too much time. He's a completely different person. And the colour of his turban changed as well.
The door study.
I'll show you one more.
The door study. This video shows a participant from a 1998 study by Daniel Simons and Daniel Levin. Watch what happens as the unsuspecting pedestrian provides directions. The young man on the left is one of the experimenters. He has approached the white-haired man and asked for directions. Watch closely as 2 people carrying a door pass between them, and the first experimenter is replaced by someone else. Like many of the people in this study, the pedestrian was entirely unaware that he was talking to a different person.
Okay, 50% of people do not notice that when it happens to them. And there is another, if you go on YouTube, there's a longer video which actually shows the person asking directions changes from a man to a woman, and people still don't recognize it. So this is all about being aware of what there's going on around you, which is really important in medicine, and that's something we try and get people to understand in simulation. That website's very interesting. It says things like, if you are with a friend and you're trying to remember what happened 2 years ago and you're arguing about it, stop arguing because you're both probably wrong. Okay? You need to tell my wife that. So the overall message is that I hope I've shown you that simulation does work in healthcare, but skills can deteriorate afterwards. But with this deliberate practice and this mastery model, getting people to feedback constantly, we can keep those skills up and make learning real. And we do know that compared to nothing, patient outcomes are definitely better. So what do we need to do in the future? Well, there's a lot of work to be done. We need to try and integrate simulation with all our training programs, both at undergraduate and at postgraduate level. And we need to assess the effect of simulation on these level 3 and 4 outcomes, whether we're making a difference to patients and making a difference to outcome in the hospital. And we need to do that in the context of not just practical skills, being able to put a drip up or a line up, but also with respect to clinical decision making and also human factors. Thank you very much.